Well, greetings again. This is Dr. Bill Wyatt with the American Orthodontic Society, and I'm going to talk about something that's very important to me in relation to doing class 3 treatments. And I want to show you why I believe this way, and there may be people that do not, and if they want to write back or video me back, I'll be glad to try to defend this method of doing class 3 treatments in many cases. Now, it doesn't work in all of them, but it works in many of them. Of course, they have to have their wisdom teeth, and they have to be in pretty good shape, for you to do this, especially the lower wisdom teeth. Now, the upper doesn't make that much difference, but just watch what happens. Now, in this first case, I want to specify that we did not do the treatment like I would like. Yet, this young man was in the Marine Corps, and they were after him to go to the war over in the East, and I really felt for him because I'm an old Marine myself, and so I wanted to really help this young man out. But they were in a hurry to do this, and you got to have some time to do it like I like to do it without surgery. So you can compare the two. Now, today I'm going to show one that we did surgically, and how we tried to retain it and hold it, and how they refused to let him wear any type of retention. And so the breakdown, what happened after the orthodontic treatment is pretty plain here. And when he came back from the service, he made it through the war without being damaged in a way, yet he was in the fast driving vehicle and out ahead of the Army, just spotting out things, and a pretty dangerous job. But anyway, he made it back safe, but the teeth had relapsed, and I'll show that to you today, and what I think would not happen if you had done it the slow way to do the correction. So let's get started here today. Let me get this thing moving. I have a little trouble starting it off. Okay, here he is when he came in for the orthodontic work. You can see, just looking straight at the facial structure, that he's a definitely class 3 case. There's no problem about that. And when you look at the side view, the chin is out there too far. And it looks like it's no question at all that the jaw is too far out, you see. So the first thing that people think about doing is shortening the jaw and bringing the jaw back something like this, and lining it up here. Well, that's not what I think. Many class 3 cases come about, and the tongue is fitting in here, pushing out on this, and it starts from maybe mouth breathing or some other things. Nearly every class 3 I've treated, there's been somebody in the family that had it, so it genetically is passed on, and maybe the genetics just makes a large tongue of the space in there, and it'll enlarge the lower jaw. So I know one oral surgeon who refuses to do these unless they do double jaw surgery and bring this upper jaw out like this, feeling that the tongue is one of the culprits. The tongue is a big muscle in here, and it pushes out, and if you're a mouth breather at all, your lower jaw gets bigger than your upper jaw, and it collapses the maxilla, And so you have to go in and kind of spread the maxilla out, or your airway is affected by reducing the maxillary, or the upper arch is narrow and everything, and that reduces the airway even more and makes a harder problem to correct that. So let's go on. That's just my own thinking in this, is that if we reduce this lower jaw or bring these teeth back, we should push these upper teeth forward at the same time. So that what we do in here is, well, let me show you on a set of models when we get to them in just a minute. Now here is the problem, and the upper jaw is more narrow in several places there, and it's off to the side, and so we are going to look at it from this angle. Now, my way of thinking in here is that if you take this 6-year molar out, now it's got to have a good wisdom tooth that's forming back here. Now the model's cut off, but the jaw went on back, and there was a good wisdom tooth in here, but it hadn't come in the mouth yet. Now if you take this tooth out, you've got a wide space in here to close up. And so you can bring these teeth back as you close the space up here, but it's better if you hook up with class 3 elastics and pull, excuse me, that's the wrong thing. I kind of screwed up there. We need to hook up the class 3 elastics and get right behind the cuspid and bring these teeth back. As we bring these teeth back, we're also pushing these teeth forward. So in a sense, by doing the extraction of the 6-year molar back here on the bottom, we'll pull these teeth back to a class 1, and we'll pull this a little bit, but not very much. And most of the tugging in here will be bringing these lower teeth back. And on the case that I'm going to show you, I'm going to do the next case in here. We show where the pagonian was sticking way out here, and the teeth were here, and then when we finished the case, the teeth were back like that. In other words, we brought the roots, the tooth, and all back in there, and that case has been out with natural retention to just keep the jaws lined up and everything, but not constantly. And that case looks just as good today as it was 30 years ago. I know the lady, know where she lives, and we just stumbled on her here in Glenrose. So this is the idea behind this, is that you sacrifice this provided you've got a tooth back in here that is good, and you bring this tooth right here up to a class 1 relationship, which would bring it out something like this. And bring it so you're not going to move this tooth very far. So we need to bring these teeth back with the class 3 elastic, which does a lot of movement of the upper anteriors, and so we wear a lip bumper up in here, going back and then kind of coming back in here and dropping down and into a tube on the brand here. Now this would be a lip bumper. Now the lip bumper we run in front of the teeth as you advance the teeth out here in front. It's necessary that you have a soft vascular bed for bone to form in there. So you don't let the pad of the lip bumper touch the tissue, and you've got to use a deal like this, and you expand that, and it keeps the lip bumper out in front of the tissue up there. Now this way of thinking is that we do most of the correction with the class 3 elastics and bring these teeth to back to a class 1 relation. In other words, this red arrow right here has got to go down that blue arrow. So we got a long way to move those teeth. There's a lot more to this than just correcting class 3. But now when we sent him to surgery, they shortened the jaw and did not lengthen the upper jaw. Well, I mean, upper jaw surgery is a major, major thing. I have scrubbed in and seen this upper jaw surgery, and it is something else. Now, lower jaw is bad enough. In other words, they crack the lower bone of the jaw. You got the teeth and everything up here, but back behind the teeth, they'll say the jaw was going this way, and a section of the jaw, they open it up here, and they grind down on one side and the other side, and the back on the opposite side. In other words, if you're looking at it, they go down on one side and then down on the opposite side, and they crack that loose, and they take the jaw and slide it forward, or they can whack some of that off and drop it backward and screw the bone together there and actually shorten the lower jaw in doing that. And that's a lot of surgery, but it's not as severe as the maxillary surgery, where they take the whole maxilla loose except for the palate or tissue, and it's just out there on the front of the mouth, and they trim the sides of the surgery down. If they want to shorten the vertical dimension of the face, they trim it down, and then they can actually back the tooth up or bring them forward and put it back together and put these plates in there, and it grows back in a more forward position. And when they do the surgery, if they do the upper jaw surgery, then the tongue has more room up here, and the class 3 case holds up better when it's done like that. So we came up with a method of treating it only in one jaw and putting some type of retention in here, that as the maxilla tended to go forward, it would actually bring everything forward on it. We'll show that. We tried that on this young man, and it's a pretty complicated retainer type thing to do that. All right, here's the other jaw, the same thing. You see, it's way out front, not as bad as the other side was. Now, let me see. I go back, I need to go down. All right, we looking at it from the front up here, you see the jaw is pretty narrow in here. It kind of goes out and comes back rather than going out and coming back in a shape like that. And that's what we'd like to end up with, the shape of it being. Now, when you develop a class 3, you develop a crossbite first, and he got to chew it on the other side of the mouth, and this side right here went way in and it missed these teeth right up in front. Now when you look at the other side, it's almost over correctly, but the maxilla is narrowed down and the mandible is widened out, and there's a lot more room down on the bottom for the tongue, and the tongue pushed these teeth out here. Now if we leave this in its position and take this back far enough to put the teeth back in the proper alignment, then we shorten the space for the tongue. Even if you widen, well, you don't want to widen the bottom, it's already wide. And you can open the upper up, but a lot of people don't do that. As they go back, they will manage to get it together without it really separating the palate and expanding the upper arch to full width and everything in that area. So now here's a few problems. The lower arch it's wider. We have some rotations that we did. They were simple to do, showing the way we use that elastic chain and slight crowding in the over interior here back this. And of course we'll take these teeth and roll them around like that. And that was the orthodontics in here. There's very little and hardly anything dramatic in the orthodontic treatment here. Now, here we are, we've come in, and this is, let's see, this is where we lined them up and everything, and the cuspid is back in the spot, and this is after the surgery. It really looks like it's okay. Here is what we did. We brought this lower jaw. We brought the upper jaw back, or the lower jaw back, really, and try to line those teeth up right in there. Now here it is, and this is how we lined it up and had everything. So this is after the treatment now. So I'm showing what we had and how we treated it. And when we get to the other portion back here, that's the way it was. And that's, let's see, go in this direction. This is the way it is, right here. They moved the lower jaw back, and they left the teeth more or less like they were, and just slips the teeth back like that. Then we look like we're on a dog fight out here. Okay, we see what they did here. Let me get my little red pen back again. Okay. Here's the way the jaw was, and now this is the way that it is after you get through with the surgery. Now there's the upper arch. It's still intact, and the lower arch, the upper arch before we started, and here is the lower arch. Now they did not remove any teeth at all. They just backed the whole thing up, and then you'd probably have to take out the wisdom teeth in a case like this. In other words, they did not change the teeth and the dimension of the upper arch or the lower arch. They just moved the lower arch back. They just backed it up like it was and left it in there. And then let's see what happened after it was in there a while. Now when the young man left for the Eastern Near East war over there in Iraq and everything, they would not let him wear a retainer. And here he is after the surgery. Now it made a lot of difference in the way he looks after the surgery. There he is before, and there he is after we did the surgery, before we took everything off and everything, finished him up. The jaw is out like this, and now the jaw is back here. And it looks a lot better. But look at where the upper arch is. If you look right at the base of the nose right here, and then you come in and look at the finished thing. We advance that now. Now look at it, and this is not hardly any difference in here. In other words, if it advanced this out like this, and brought it and given the tongue more room, this possibly would have stayed intact. But they went over to the into active duty, and they took the retention off. They wouldn't let him wear anything at all in there, and so this thing relapsed. And so I'll show you what happened after he got home. So this is 1988. Now before he left, we put him in what I call class 3 retention. And if you do a surgical case and the surgeon doesn't want to do the maxillary arch, you can use this retention and it will help maintain this where it is. In other words, if the tongue comes in there and pushes on it, the elastics, if they wear them, will bring the whole mouth structure forward in there if you retain it like that. Other than that, it's going to shove this part forward and not this. But we put this elastic in there. As this tries to come out, this rubber band brings this part out. And we can hook this up to a retainer. And we take all of this off. I mean, everything is off, but we bond the lower anterior teeth together from bicuspid to bicuspid. So it's in one unit. And then we hook this to the cuspid and we hook it to the retainer, and we fix the retainer so it will hold up and it will just pull the upper arch forward as you advance the lower arch. Now, that may be confusing to a lot of people, but let me show you how it works here. Now, I can make this upper retainer and put here's your arch wire right there on the side of the tooth, and we can come in and put composite down here. This is a bunch of real good composite, and it's in just a wedge. And if you push that in, it'll snap this wire out, and it'll snap into that, and you can hardly get the thing out. Now you have to make it, and we have somebody show them how to prise this out from one side and slide it down, and then the other side will come out. But this rubber band playing against the retainer will not pull that retainer out of the mouth, and these teeth tend to come down, but the occlusion keeps them up in pretty good form. And this type of retention, if the tongue wants to advance this part, it's going to have to carry the maxilla along with it. Now, I don't know how many of you have ever used that. That's something I just came up with myself, is class 3 retention. And the oral surgeons love you, so they don't have to do the upper jaw surgery if you use this type of retention. And it just seems like people just don't try it, and they don't really think it out. And they ought to teach this in the oral surgery department. If you're just going to operate in that one jaw, moving this back, you better put up some type of retention that's going to bring the maxilla along with the mandible, because I've had several oral surgery cases that were class 3 that relapsed. and I figured this out. And the oral surgeons were real happy to do that. If you'll go in and put retention as the lower jaw wants to come forward, it's got to bring the upper jaw forward. And that's a neat trick and should be taught in oral surgery school. If you don't want to do the upper surgery, and the upper surgery is more dramatic than the lower surgery, you can shorten the jaw, line the tooth up, put this type of retention in, and if you wear it, now let me show you these. We take the braces off these front teeth down here, but we bond the inside of this. And surely I've got a picture of that, but that's on the other side now. And you build your retainer with a nice hook back here in the back. You hook your elastic up, you snap that retainer and hook that elastic, then come down here and hook it to your cuspid tooth. And you can pull on that retainer all you want to with that elastic, and it's not going to pull it out of the mouth. And you put this wedge of that excellent composite under your retainer wire, and it'll stay in. You don't need any clasp on these retainers. You shouldn't have anything crossing over the occlusion. Some people, they'd have to put a whole bunch of, they don't hold anything like this holds. This thing will hold that retainer in there, and if it moves it down, the occlusion hammers it back up. So this is something that every oral surgeon, or anybody that sends cases into the oral surgeon, and actually the tongue frequently is the thing that causes that they get to swallowing wrong, and the tongue gets wider and the maxilla gets more narrow, and they go into crossbite, and so the jaw kind of sticks out and the tongue comes in there. Now, go ahead and advance the maxilla. As the mandible tries to go back, let this rubber band right here, if they'll wear that thing, it'll take this whole maxilla forward right here. So they go to forward together, and that's good because it gets to where the tongue pressure in here is the same as the lip and the cheek pressure, and how people pull their lips back and everything, it carries it out like that. So it takes a little thinking on the part of people going in here and doing this, but this is the thing looking up now. This is that molar tooth, and the arch wire's running right through here, and we put this composite right under here, and you snap that arch wire over that hump, and you put one in and then snap one over. It'll hit right here and just kind of stretch out in this direction, and then just snap down in there, and you hook up elastic up here, and you pull it forward like this. You will not pull it out of the mouth, and that's what I call I call class 3 retention. And this is something I came in, put in there years ago. And if you do this, you can take surgery that needed the maxilla worked on and brought forward. And there's some oral surgeons, I know one of them is an excellent oral surgeon. He does a double jaw surgery virtually every time he does it. And then his stuff doesn't relapse like people that, I've had people that had me wear class 2 elastics. In other words, they were coming in with class 2 elastics to make this problem down here a lot worse when they do the surgery. So they put them back further than they really wanted them. And then as the jaw came back forward, maybe it would fit in there better. Now, that may work for some people, but that's not what you want to do. Really, you want to put the thing together and then have it move as a unit, the tongue, and that's what we're trying to do here in this case. Okay, now the lower anterior, when we get ready, we're lined up like this around here, and we had a deal on there pulling that too. That's not what we want to do now. Now there's a better view of this hook. The retainer wire goes around like this, and you solder this hook on, and then it goes out here and tucked where it doesn't hook the bottom guy, and the wire's just sticking out there. You can hang an elastic on that and pull it in this direction. Now here's the composite over this wire, and you will not pull that wire off that tooth pulling with this elastic. And if you do, you didn't get a big enough wedge in there, because it ought to fit in there and just snap in. Now you just put one side in and then you snap the other one. When you go to come out, you bring one side out and bring it down, then slip it down to the other side. But that will hold that elastic back, and you can put quite a force out there to have on those lower anteriors. Now let me see. There's another view of it. Give you an idea how to do that. And there's the upper arch, and there's the elastic coming down with the mirror. That's not two, that's just stuck a mirror in the mouth, and this is the mirror picture of the elastic that's hooked in there. Now, here we've taken the brackets off, and we've got some decalcification in here, and we have bonded this heavy wire all the way on all of these teeth. They're bonded on real good, and you pull back from here and over here, and as the tongue pushes this forward here, the upper jaw with these teeth over here comes forward with the mandible, and so that the equal pressure on the inside still counts. You got to have the same amount of pressure inside as you do outside, and that equals that back up where your surgery changes the equalness of this, and you bring the jaw back underneath here, then you've got more pressure on the lower jaw. And class 3 surgeons are afraid they will have to go back. They do, many of them go back again and operate on her. This is the way it used to be. Surely they have waked up to the problem, and this is the way it should be done, and that's my thinking. And old surgeons and other people, if you disagree with me, go ahead and let me know. If you've got a better way to do it, I would like to know it, and I would change and do that. But I tell you, this is a hard way to beat that problem. And there, the lower, it's a 4 to 4, and that rascal stays in there, bonded with excellent acrylic. And you can drop your dental floss in from the top, hanging it down where it'll cover that, or if you want to push underneath here and keep that clean, and that needs to be in there, and they need to watch that for several years to come. Now, I haven't gotten too many people that will try this. I mean, they think it's impossible for them to do. It's not impossible, and you can do it, and you can take a surgical case that really ought to have the maxilla brought forward a little bit, and you can do the surgery, and then you can put this type of retention in it, and I guarantee you, if they wear those elastics on that, and that mandible moves forward, it's going to move the maxillary teeth forward too, and that's what it will do, and I will guarantee that that will happen in there. You put that force on there. Now, if somebody just screws around and wears it whenever they think about it, it won't do it. But if you wear that thing at least every night and part of the time in the daytime, you'd put that elastic force on the maxilla and you will move it forward. And I'll stand by that. And so, anyway, if you try it and it doesn't work and you really do, I'd like to know if you come up with a better way to counteract surgery that needed the upper jaw advanced and it's had the lower jaw brought back further than it wanted to be, and you can figure out a better way to keep it out there, well, let me know about it. So thanks for watching this, and here the retainer is hooked up like that. And I'll tell you, you put that elastic on there and you keep that thing in there, it will advance that thing. It's no question. See, this point of this really ought to go down in there. Now, they would not let this young Marine wear this retainer, and when he came back, it was broken down. And there, I think that was still in there. Now here, but he did not get to wear it, so it's got some breaking down of the class 3 surgery that we did. And here he is. He still looked good enough, so he decided not to try to do that. But we've lost part of the correction. You see, this is after he's returned. This cuspid should go down in there. This point right here ought to be back in here, see? And see this molar? See, it's further forward in here than it should be. And he's got an end-to-end anterior part of the mouth. That relapse during the time he was there and could not wear this thing. He didn't brush his teeth all that good either, so I see some problems there. Okay, and that's from that side. This is 91, he came back. But he got back alive, and it's worse on one side than the other. And that's his upper arch, got a cavity in there, and that's the lower arch. Though he wasn't wearing it, boy, these teeth stayed there. I mean, they stayed in their place, and he could actually put his retainer in it if he's got the. Let me see, on the upper arch, that stayed. He's got a little decalcification and probably some decay on some of those teeth. But here he is, and that's the end of it. And I thank you for watching this, but this is a important video to me, and I hope you will study it. If you do class 3 correction in your office, you ought to know what to do here and how to do it. And I hope that surgeons will look at this and see and help promote this retention. If you're going to do things that you need to advance the maxilla, you can just look at him. See, this part of the face, excuse me, this portion, well, that's screwed up there. The upper part of the face, right under the nasal cavity. I mean, the nasal is right in here, should be out further. You can see that needs to come out further. So but he decided he'd just leave it alone rather than go back in there and try to do something with it. But I would like to go back and do it. But I thank God he made it back alive. So I'll sign out, and we've spent a good many minutes here, but to me this is an important thing to know in orthodontics for anybody who does any class 3 work, surgeons, orthodontists, and whatever in there ought to understand this problem. And we're going to take you into a case now tomorrow, or it'll be number 2, that we did the same thing except we extracted the lower 6-year molar. And that made a tremendous difference. And we advanced the maxilla and used a lip bumper in pushing it, getting this vascular bed, and it brought the teeth forward. And I've got that case about 30 years out of treatment. She's an airline stewardess, and I'll show you that the next video. We'll be following this one. Thanks again for watching, and join our group. And I'll say goodbye, and enjoy getting together and talking with you. I wish it were a class and I could have communication back and forth. So I'll say goodbye. Bye-bye.